All right, so far we've gone over several kidney conditions. Now we're going to move into carcinoma. And two examples I have for you of bladder cancers. Okay, the first of which is renal cell carcinoma. And this is the most frequently occurring kidney. And what it does is it begins in the lining of the proximal convoluted tubule, if you can imagine that PCT. So this will be out more in the periphery of the kidney, and it's linked with being male and smoking, okay? So it can metastasize, obviously. It seems to really like to go to the liver, the lungs, and bone, unfortunately, and nervous system. Seems like a lot of things like to go to liver, lung, and bone is what I was thinking. So it'll show up as asymptomatic, painless blood in the urine, abnormal urine color, that flank pain once again, and weight loss. Weight loss is always going to be a bad thing. Okay, so that is of the kidney. Now we're going to look at bladder. The bladder cancer will start in what's called the transitional cells of the lining of the bladder, or the squamous cells, which are actually close to the lining as well, or in glandular structures called adenocarcinoma. There's little mucus secreting structures in the lining. So we can have bladder cancer starting in any one of those groupings of cells. I'm going to show you a picture of the transitional cells in just a minute. This also likes to metastasize. Okay, there goes to liver and bone. So advancing age, males, smoking, chemicals, I think there's a strong link with alcohol as well with bladder cancer. So once again, if we have painless blood in the urine, bad, right? Abnormal urine color, UTIs, back or abdominal pain. So let's look at the cells of the bladder. So we've taken out just a little of the lining of the bladder. I don't want to get too cellular, but I also feel like you need to know some of this. If you look at all of these cells between the two red lines that I just created, and each one of them has a purple dot. That's the nucleus of each one of these cells. Their shapes and sizes are all over the place. Some are tall, some are wide, some are thin. These cells line the bladder, and they allow our bladder the ability to stretch in multiple directions. Okay, so if we had very thin, tall cells just going in one direction, it would only stretch really well in one direction. But because it has a whole bunch of different shaped cells, it allows the bladder to stretch and then also shrink and stretch and shrink and stretch and shrink. So we can get cancer from this transitional epithelium, and it's called transitional because it has a transitional shape, has multiple shaped cells. There's also squamous cells, which is a thin layer of cells, I think, that can actually lie on top of here from what I read. That doesn't quite make sense to me, but don't worry about that. The squamous cells, and then we can also have it from glandular secreting cells. So there'll be groupings of cells. These are probably little groupings if they're not blood vessels, but they'll look like little openings down here that'll secrete mucousy structures to the surface. That adenocarcinoma can happen in those types of structures. Okay, so 3 groupings of cells. Now, moving on to benign prostatic hypertrophy. And this will be a benign, which means it's not cancerous. Of course, we could get prostatic cancer, but we're talking about benign. Benign enlargement of the prostate usually just happens in males as they get older. The change in hormones, the decrease in testosterone actually causes that to grow a little bit. But as we get older, the prostate also continues to grow. In males, I think it's mostly more of an issue with urination and UTIs. It's nothing dangerous unless it completely cuts off the urethra. Hopefully it doesn't do that. I'm going to show you the anatomical structures in the next picture. So a frequency and an urgency to urination, but then they have difficulty with urination. So they have the urge to do it, but then they have a difficulty completely voiding and having a strong stream. So looking at a view of the male system, we have the bladder here, and I'm going to go over the full reproductive system in the next collection of notes. But for right now, let's just look at the bladder. Just underneath the bladder, we have the prostate. The urethra comes from the bladder through the prostate, comes through what's called the corpus spongiosum in the penis, and then out the urethral orifice. So this little section right here of the urethra is the problem. And you could see the prostate, if we switch over to this picture, completely surrounds the prostatic urethra. So you could imagine if it grows, it could push in on the urethra, and it would make it difficult to get urine from the bladder out through the urethral meatus. So that's the gist of BPH. Polycystic kidney disease is inherited, so this is genetic, and they get multiple cysts in the kidneys. So this will compress the kidney tissue, but it also replaces the nice functional nephrons, and they will have a decrease in their filtration because of their lack of nephrons. Instead of having millions, they'll have 500,000 or 1,000,000. I'm not sure the number, but you get the idea. So prognosis and progression varies widely depending on the type. We have autosomal dominant. Okay, so these are in chromosomes 4 and 16. More common in adults. They usually don't show up until middle age, as opposed to recessive. It is less common but more serious. Because this appears in infancy or childhood, it's more aggressive. You're going to have more cysts earlier. It'll progress rapidly, and then it can lead to end-stage kidney failure. Okay, so autosomal recessive. I would know the difference between those. Those seem like they would be good questions to ask. Okay, so dominant is going to be less of a problem. Recessive is going to be more aggressive. So let's practice. Guess the disease process. This one's so easy, I'm just going to help myself. So now we know those anatomical structures. There's normal prostate as opposed to BPH. What do you think this is? Oh, this poor person. Oh my God. Could you imagine? I know you know what this is, but polycystic kidney disease. It's just awful. Awful what can happen. Okay. What do you think this is? So this is obviously kidney. It looks like there's a tumor in the periphery. Yep, it's going to be renal cell. And then this one, if you can see, this is going to be a bladder. You can see the trigone there. Right in front of the trigone, that doesn't look quite normal. It's going to be a bladder cancer. Okay, it's going to be on that surface once again with that lining. Moving into renal failure. Okay, so we have acute or chronic, and you probably know a bunch of this, but let's go over the actual specificities of it so we know what we have to remember. So acute will be obviously sudden. This is generally reversible. So there can be either something wrong with the kidney itself or something in the systemic circulation or after the kidney that can cause acute renal failure. We're going to go through all of these steps. So obviously being older, darn age just wrecks our body. Things just break apart. Autoimmune disorders, liver disease could lead to this as well. Lots of things can lead to this. And the way that we'll classify this as pre-renal, so that's going to be something that's going to decrease the blood flow getting to the kidneys. Heart problem, shock, blockage, clot, okay? Anything that affects that blood flow getting down to the kidneys via the renal artery, okay? And they have them labeled to the right here. I actually found this picture for you. Okay, so here's prerenal. So anything that interrupts this blood flow. 2 is intrarenal. That'll be something in the kidney itself. So direct damage to the kidneys, toxins, drugs, infection, reduced blood supply due to something with those afferent arterioles leading into the nephrons. Okay? And there's other things as well. Those are just some examples. Post-renal is obstruction of urine flow due to prostate, right? Kidney stones, bladder tumor, injury, something that's going to block that flow down. Okay? So we're either not getting enough blood in, we've got damage to the kidneys, or we've got a blockage, which will probably back fluids back up. Or not let fluids out. So here we go. Prerenal, intrarenal, postrenal. I think you've got the general gist of that. There it is listed out again. Okay, so different phases. There's an asymptomatic phase. We can usually compensate for a little while. Okay, if it continues though, it'll move into oliguric phase, where daily urine output, oliguric. Daily urine output decreases to approximately 400 milliliters or less. So then waste products will begin to accumulate. Hopefully, you start to move into the next phases to recovery, and you'll have a diuretic phase, where daily urine output increases to as much as 5 liters per day, when we should be between 1 to 2. Your recovery phase, eventually things, hopefully, if whatever is wrong is taken care of, the heart is taken care of, the blood clot is removed, the blockage of the kidney stone is removed, whatever, if that is gotten taken care of, they can undergo recovery. Okay, so decreasing urine output, oliguric, phase, will cause, because you're not getting rid of the urine and you're not getting rid of the proper electrolytes, not only do you retain fluid, you retain waste products, you retain uric acid, you retain urea, right? You get the idea. So, that will not only retain fluids, it'll offset the balances throughout our body, okay? So diuretic phase can do the same thing because we're getting rid of too much, right? It'll lead to dehydration and hypotension. So azotemia, I wanted to put as a little separate sidebar, is going to be toxicity in the blood with an increase in BUN and serum creatinine levels. Okay, so those would be something that you're probably working with every day and you're familiar with, but I just wanted to put it as a little side note. Okay, so if BUN levels go above 20, there's going to be an issue, right? Same thing for serum creatinine, above 1.4 milligrams per deciliter. Okay. So question time. Steps to monitor a patient in acute renal failure or injury is measuring output, urine output, BUN levels, serum creatinine levels, all the above. You got this. So if it continues, God forbid, acute renal failure, so if their problem's not gotten taken care of, or they have another problem that leads to chronic kidney disease, that is what we're going to talk about now. And this is a gradual loss of renal function that's irreversible. You see there's a million causes to this disease. And once again, I wouldn't list these, but have a general working knowledge of things that might cause this chronic kidney disease. And it would be your chronic diseases, your diabetes, your hypertension, renal diseases, renal artery stenosis, things that are going to create permanent issues that this patient has to keep dealing with. So the different stages I think are good to know, and these are monitored by glomerular filtration rate. Okay, stage 1, we have kidney damage present, but GFR is greater than 90. Okay, so it's still normal. Stage 2, kidney damage, GFR falls, 60 to 89. Stage 3, kidney function is significantly impaired as GFR is between 30 and 59. Stage 4, you get the idea. Those numbers lower to 15 to 29. Stage 5 is kidney failure. GFR drops less than 15. Patient begins dialysis. Okay, so I would know a general working knowledge of those numbers and also that dialysis is going to happen at stage 5. I'm sure there's a little bit of variation with that, but those are the standards that we're just going to go with so we know we're all on the same page for exams. So, manifestations, anything that you can think of, right? Oliguria, less than 400 milliliters a day as opposed to anuria, which is less than 100 milliliters per day. So I would know the difference between those urinary outputs. You probably already do, right? Just trying to be clear. Dark colored urine, because obviously they're not pushing enough fluids out. The rest of this are all things that we've talked about, excuse me, with disease processes, you know, electrolyte imbalances. You'll get edema, so you could get pericarditis and effusion and pleuritis and pleural effusion, congestive heart failure because of electrolyte imbalances, respiratory distress, sudden weight change, edema, obviously, azotemia, the retention of those waste products, okay? So I left those manifestations on once again, and like I said before, I wouldn't ask you all of them. I want you to have a general working knowledge of what could happen. Okay, so it goes on. Okay, flank pain, jaundice, persistent pruritus. People start to get very itchy. I know that you guys know that as a side effect of these kidney disease because of the buildup of the urea and uric acid. Okay, so boy, that would be a scary thing to have. All right, we're going to move into our last question. So, and then we are done with urinary function. Now, I want to know, I have put several videos for urinary function because I know it's complicated and it's not quite a super long lecture, but it's really good to review these things. I have a really good video for the anatomy and physiology of the kidney. I also have a really good video from one of the NCLEX reviews that I put for acute renal failure or injury. So watch both of those. That's probably another 45 minutes, but I think it'll be a good review for you. I won't ask you questions from those videos unless it correlates to what I've gone over in this lecture. So you'll see they go into some things that I didn't go into. That's fine. Like the NCLEX review goes into a lot of lab values. You know, if I don't have it in this lecture, I won't ask you it on your lecture exams, just as a side note. All right, so question time. A patient with stage 5 of chronic renal failure never needs dialysis, true or false? And you got that. You are rocking this. As always, I am Dr. DeChavo. If you have any questions, please shoot me an email. Otherwise, I will see you in reproduction. Have a great day.